So what is the differential diagnosis for the chest pain? So differential diagnosis, just now we discussed so many varieties of the chest pain due to so many causative factors. So is chest pain is due to anxiety or emotion. So who are having some stress, anxiety and depressions. So those people feel always the chest pain or because of the emotion, and also cardiac related. So it's because of the any involvement of the like a heart blood vessels, and also the oxygen supply and blood supply to the heart muscles. So this also one of the cause to factor. And also aortic one because of the dissections or maybe any stenosis, esophagus, and also any lung or pleura, musculoskeletal, or because of the neurological. So these are all the differential diagnosis. So it will be very, just now we discussed, so we are going to discuss one by one here. So in the anxiety, so this also common cause for the atypical chest pain. So they're having any anxiety and depressions may chance to get. So that is mainly the lack of relationship with the exercise. So if anybody having unable to, know, if they are sedentary lifestyle, so if there is no like exercise, if they are not doing regular exercise, so and also if there is anything with any receiving any bad news. So if any bad news, if there is no proper exercise, or if there are the anxiety and depressions, so those people are may chance to get the chest pain. And also another one is the cardiogenic. So just now we discussed the related to the myocardial ischemia, and that is the blood circulation, and also myocarditis, that is inflammation of the muscles, pericarditis, mitral valve prolapse, and also another one is the pain in the felt and the retrosternally to the left to the sternum, or in the left or right shoulders. So if anybody having the shoulder pain, and also retrosternally, so behind the sternum, and also intensity varies with the movement and also phase of the respirations. So they may chance to get the sharp and may catch during the inspirations, or coughing in the lying in the if they flat lying down, so they will get the cardiogenic pain. And occasional history of the predominant viral illness also may chance to get the this myocarditis, and because of the pericarditis, it's inflammatory. So especially for the inflammations, so they are going to get the chest pain. So that is the difference between the heart and also the non-cardiac conditions. And also this aortic one, just now already discussed, the aortic dissections and also aortic aneurysms. So this going to pain is severe, sharp, and also tearing sensations, and also penetrating through the back. So is going to be abrupt onset. Pain follows the path of the dissections. So how the dissections takes place, how the bleeding, so how the leaking is going to be happen. So they are going to get the severe pain along the pathway of the dissections. So if a dissection, so here is going to be three types of the dissections. How the dissections is going to be happening. So there they are going to get the that means the bleeding. So how is going to be happening. So how much the which directions is going to get. So that the area is they are going to get the pain. And also next one is the esophageal. So esophageal means is because of the any like a the foot pipe. You tell nothing but the foot pipe. If any abnormality in the foot pipe, so they may chance to get the chest pain. So these are all the especially is the any inflammation of the esophagus, that is the foot pipe, or any spasm. So any tightness of the any smooth muscle tightness, or any is a Mallory Weiss syndrome. So and also pressure tightness, and also they may chance to get the burning. So they feel the pain in the retrosternal. Behind the sternum, they are going to feel the more pain. There is not, it won't be like a diffuse. It's a localized pain, and also it's a mimic like a angina. It's very closely. So this condition is like how in the angina chest pain they are going to feel. So it looks like it's the angina pain, but sometimes precipitated by the exercise. So if any, so it's going to aggravate, or is going to be with the exercise. So sometimes relieved by the nitrates. So this also some is going to be, if they take sometimes the nitrates medications, it may give the reliefness. Illustrate the history of the chest pain to supine posture, or is the eating, drinking, or esophageal reflex. So they may chance to while doing the like having food or having drinks. So that time also they may chance to get the in the supine positions. So they may chance to get the esophageal reflex. So this may kick or regurgitate. The pressure is going to comes from the stomach to the esophagus. So they may chance to get the burning sensation. So they may feel the regurgitation force in the chest. So that is because of the esophageal reflex. And also sometimes this may radiating to the backside. So because of the irritation of the mucosa, so may chance to give the back irritation. It may radiate to the backside. and also because of the lung and also pleura. So pleura is a covering layer of the lung. So any spasm, bronchospasm, any restriction because of the any congestion in the lung or any pulmonary infarct or any decrease the blood circulation in the lung, or in case of pneumonia, infection, and tracheitis, inflammation of the trachea, and pneumothorax, air enter into the pulmonary pleura, and also pulmonary embolism if any blood clot the break and also is travel in the bloodstream and stuck at one particular place, or any malignancy or any tuberculosis. So these are the causative factors for the lung pain due to like a lung diseases. Bronchospasm, so this is going to be irreversible. Airway obstruction in case of the asthma, so or in case of the exertional chest tightness, so that also relieved by the rest. So in these conditions, they may chance to get the chest pain. So especially in the pneumonia and pleuritis also, they may chance to get the sharp type of chest pain. So these are the differential type of the chest pain compared to the, if you compare with the cardiogenic and also non-cardiogenic chest pain. So next one is the musculoskeletal. So the musculoskeletal. So these like a any injuries such as any rib fracture or any injury, any accidents, or in case of osteoarthritis or any costochondritis. So that means the inflammation of the costal and also is and also next one the intercostal muscles. Any the rib if any muscles attached to the ribs. So these intercostal muscles injury or is any myalgia is so may chance to get the this musculoskeletal pain. And also this pain or this aching is variable in site and also intensity. So the site is going to be totally different. The intensity will vary, depends upon the cardiac and also non-cardiac disease. So it may vary with the posture and movements. So if they change the posture, abnormal posture, they may chance to get the like a, intensity and also the variations may happen in the pain intensity, and also in the movement if they do the arm movements and overhead activities and sudden twisting or bending activities may use the this severe pain, and also it can be accompanied by the local tenderness over the rib or costal cartilage. If you press over the chest regions, so it gives the tenderness. So it'll give the, if you press they are going to get the feel the pain, so that is called as tenderness. So these injuries are related to the everyday activities or viral infections. So this is going to be because of the improper activities or the sudden any exercise modifications. The first time initial first day exercises also may chance to give the like a chest like a tenderness, or maybe is because of the like a strain or stress may chance to get the pain in the musculoskeletal. So and also neurologically, so it's because of the herpes zoster, so they may chance to get the viral viral infections, that is herpes zoster virus. So this also may use the sharp and burning sensations. So this also may produce the pain in the chest region, and also in case of the prolapsed intervertebral disc. So any disc prolapse, so the nerve is going to be compressed. So because of this thing also, it may radiating to the chest. It may give some chest pain. So these are the some neurological diseases, especially in disc prolapse and also herpes zoster. Thoracic outlet syndrome. In thoracic outlet syndrome, the nerve is going to be compressed between the subclavian muscles. The thoracic nerve is going to be in. So it also produces the pain in the chest as well as the radiating pain into the upper limbs. So these are the causative factors because of the neurological disorders. And also next one is going to be the stable angina versus acute coronary syndrome. So how we are going to differentiate with the stable angina, and also we are going to see the acute coronary syndromes. The stable angina, so if you see here, so what are the features? So the comparison between the stable angina and also acute coronary diseases. The pathophysiology, if you see the pathophysiology, so the coronary, acute coronary syndromes are going to be is there any like a thrombus formations or maybe any rupture, so may chance to get the acute coronary. So this one is going to be stable, means inside the fat accumulations, because of fat accumulations the blood vessel is going to become narrowing. So because of the narrowing, the blood circulation is going to decrease to the muscle tissue, so it may chance to get the severe chest pain. So if you see the pathophysiology is going to be the fixed stenosis. The fixed stenosis means because of the fat accumulation, the blood vessels, the wall structure is going to be narrow. So it's going to decreasing the is going to space is going to be decreased. The blood circulation flow also going, the pressure is going to be increased. So may leads to the decrease the blood circulation to the tissues. It may produce the chest pain. And also stable fibrous plaques. So if you see here the fibrous plaques, the fat plaques are going to be stable. So but it is going to be gradual, this the gradual changes. But in case of acute coronary syndromes, so it's going to be dynamic stenosis. Dynamic stenosis means already they're having the fat depositions. So these fat depositions again is going to get the any clot or any bleeding or any maybe is going to be stuck here. So is any plaques are going to be ruptured. So if any rupture of the plaques, so it is going to stuck in between the like a stable plaques, so it may use the decrease the blood circulations. So that is the pathophysiology of the stable angina and also acute coronary syndrome. The clinical features are, if you see the clinical features, so this is going to be the demand-led ischemia. So this is going to be the ischemia is there, so they are going to get and also chest pain repeated to effort, sorry, related to the effort and also predictable symptoms over long term. So these people are going to be like a they get the chest pain, but it's going to be a long term. So it is a chronic symptom they're going to feel, and if they take some medication, it's going to be subside. Again, they may get the pain because of this is the stable changes. But here is going to be the supply lead ischemia. So it's going to be so the suddenly they are going to get the decrease in blood circulations. So symptoms also they are going to get the rest is unpredictable symptoms over the short term. Within the short is acute conditions they are going to get the symptoms, and also frequent also nocturnal symptoms. So they are going to get the time to time and also frequently they are going to get the symptoms. So these are the difference between the stable and also acute coronary syndrome. The risk assessment here is going to be, so we have to find the symptoms on minimal exertions. So this one is the duration of exercise, degree of ECG changes, abnormal BP response, and also CT coronary angiogram. So with this one easily we can find the so where exactly having the problem. So with the ECG changes, any blood pressure changes, and also if you do the CT scan or angiogram, so we can rule out the causative factor easily. But here is ECG changes at the rest we have to found it. ECG changes with the symptoms and also elevation of the troponin. So we have to check the any troponin level is increased or any changes in the ECG. So these things we have to compare in case of the acute stable angina and also acute coronary syndromes. So if you relate, if you see the comparisons here is going to be unstable. So here stable angina, the effort related chest are choking in the chest. So they may chance to get the choking, and also relationship with the physical exertions, they may chance to get the chest pain. The duration of the symptoms should not be noted because patients with the recent onset angina are the greater risk. So they are going to be the recent angina, they are going to get the more like a symptoms. So here acute coronary syndromes are going to be urgent evaluations because of sudden onset. So there is maybe the prolonged and severe cardiac like a chest pain. So they have to differentiate. Stable one is going to be the stable. That means they can get the pain and also this is going to be subside with the nitrates. And this one is going to be sometimes they may won't get in the with the nitrates. So these are the difference between the stable and also is the acute coronary syndromes. So the physical examination is going to be the risk factors we have to identify. Is there any xanthoma indicates any hyperlipidemia? So that means hyper like a fat accumulations, any left ventricular dysfunctions, or any like is dyskinetic, the apex beat, gallop rhythm. So all these things we have to identify, and also if anybody having any peripheral vascular diseases, and also untreated conditions may exhibit angina. So because of the peripheral like a vascular disease also may chance to produce the unstable angina. And acute coronary syndromes we have to do the according to the signs and symptoms such as the like any comorbidity risk factors related to the like a peripheral vascular and also cerebrovascular diseases, or maybe any autonomic disturbances such as the pallor or maybe paleness or sweating, and also complications such as any abnormal rhythm of the heart, that is arrhythmias, any SA node or AV node conduction block, so may produce this sudden or acute coronary syndromes or is unstable as anginas. So what is the difference between, so here is unstable anginas, the coronary artery diseases, aortic valve diseases, hypertrophic cardiomyopathy, angina, murmurs, echocardiography. So these are going to be under the stable angina. And here the blood test should be how to go for the blood analysis, full blood count, and also the sugar levels, fasting blood sugars, lipids, and also TFTs and 12-lead ECG, exercise testing, coronary angiogram. So if anybody confirm with a stable angina, so they have to like a total pulmonary lung function test and also coronary angiogram is a, so they have to go for the evaluation. So coming to the acute coronary syndromes, so hemodynamics, so they have to check for the is any signs of the hemodynamics such as hypotension, pulmonary edema, and also for them we have to immediately do the ECG test, any ST segmental elevations, so and also any biochemical markers that is troponin elevations, and also in case of the we have to do the 12-lead ECG, or any changes in the new ECG changes, elevated plasma troponin concentration confirm the diagnosis of an acute coronary syndromes. And also exercise test or CT coronary angiogram to diagnose the underlying coronary heart disease. So for them also we can do the CT scan of the coronary angiogram and also for mainly rule out the any coronary artery diseases. So these things just now we discussed. So which type of the pain we can predict the what is the causative factors. So here you can easily understand so what type of the causative factors is going to give the the clear information, the picture. Or if, for example, if you see the angina, the duration of the symptoms are going to be the 2 minutes, are going to be the less than 10 minutes. So the pressure is going to be the tightness, pressure, heaviness, and burning. And also the location is the retrosternal, is often with the radiation to the or isolated discomfort in the neck, or jaw, or shoulders. So is frequently the left side. So this is going to commonly seen in the angina. So, and also the precipitating factors are going to be the exertions or in case of any exposure to the cold, any psychological stress. So the sound, the heart sound, the gallops and the mitral regurgitations, the murmur during the pain. So we can found this one is the heart sound 4. We are going to found at the mitral regurgitations, murmur during the pain. So we can found associated features are there. Is an unstable angina is going to be the 20 to 10 to 20 minutes similar to the angina, but is going to be the severe pain compared to the stable angina. So it's also same like the retrosternal and also same like is going to be like the angina symptoms. But the low levels of exertion or even the rest also they are going to feel the pain in the unstable angina. In case of acute MI, myocardial infarctions, so it's going to be is more than 30 minutes. So if anybody having pain less than 10 and also 20 minutes, so we can predict this is related to the angina. But in case of the acute MI, if it will be more than 30 minutes. If more than 30 minutes, so the symptoms are going to be the angina, but severe like we already discussed how they are going to be with the hammer and also squeezing and crushing. So the type of symptoms are going to be feel. So same the pain also is going to be retrosternal and also this is unrelieved with the nitroglycerin, maybe associated with the heart failure and also arrhythmias. So this is the difference between the unstable angina and stable angina also is a myocardial infarction. So next one is the aortic stenosis. So if the duration is going to be recurrent episodes, so there is no constant. So sometimes they're going to feel the pain and also sometimes it's going to be relapsing. So same, the pain also same like angina, but the location the same, location also same, the retrosternal and associated features are the late, then also peaking systolic murmur radiating to the carotid arteries. So it's going to give the radiating to the carotid arteries. And also these symptoms also like a pericarditis, these hours to days may be episodic. They're also going to get the hours to days, so may chance because of the inflammatory conditions, because of the inflammation of the pericardium, so they may chance to get the severe pain, so it days to hours to days together. So the pain also is like a not like a same angina, but it's a sharp like pain. It is not like a tightness or heaviness, but they feel the sharp like pain. So they will get the retrosternal towards the cardiac apex. So that is cardiac apex is the intercostal fifth intercostal space. So if you see that space between the rib cage, the fifth intercostal space, the apex is there. So there they are going to get the more pain in case of the pericarditis. So it may be relieved by the sitting up and also leaning forward, the pericardial friction rub. So this is going to be relieved with the positional changes. They may chance to get the less pain. Coming to the aortic dissections, the abrupt onset and also unrelenting pain. So they're going to get the like a tearing pain, ripping sensation, like a knife, like how they with a cut with a knife. So they are going to feel the like a pain, like a knife cut. And also it is going to anterior chest, often radiating to the back between the shoulder blades. So it's going to get the anteriorly and also mostly is going to distribute to the in between the shoulder blades. The associated features are hypertension, underlying connective tissue disorders, and Marfan syndrome. So they may associate with aortic dissections. And also pulmonary embolism. So these are also is abrupt onset, several minutes to few hours. So this is going to be the pleuritic symptoms. The pleura is going to inflame how there's like a their severe sharp like pain. So this often lateral to the side of the embolism. So often lateral. So for example, is going to be away from the body. So is goes the side of the embolism. If the side, if you go to right side, so is my right side, is my left side, but towards the lateral side. So because of this embolism, so they may chance to get the dyspnea, tachypnea, that is difficulty in breathing hyper like increasing the like a breath rate, and also tachycardia, heart rate is going to be increased, and may chance to get the hypotension, decreasing the blood pressure. Also, they may chance to get. These are the associated features with the pulmonary embolism. Next one is the pulmonary hypertension. So the pain is going to be the variable. Is the pressure. They are going to get the substernal along with the associated features of the dyspnea, signs of the venous pressure including edema and also and jugular venous distension. So they will get the distension in the jugular vein. So these are the clinical features of the pulmonary hypertension. So pulmonary pleurite, pneumonia and pleuritis is going to be variable, and also pleuritic symptoms. Unilateral is a localized one. Dyspnea, difficulty breathing, cough, fever, rales, and occasional rubs are going to found in the pneumonia. So these are the associated features, and also spontaneous hypertension. So the pain is going to be sudden onset, and also maybe several hours may chance to get. This also pleuritic pain towards the lateral side, so side of the pneumothorax. If any pneumothorax means is related to the any air enter into the pleural cavity, so may chance to get the this pain. So these are also will get the difficulty in breathing and also difficulty in the decrease the breath sounds and also side of the pneumothorax. So if the right side pneumothorax, if the air enter into the right side, so that side the breath sounds are going to be decreased. And also esophageal reflux, so it will be the 10 to 60 minutes. So because of the gastric problem, so they will get the burning and also substernal and also epigastric. So in between the sternal and also epigastric level at the stomach gastric levels, and also it is worsened by the is a postprandial. So after the food they are going to get the like a severe pain, or maybe the sleeping recumbency, and also recumbent relieved by the antacid. If they take the anti-acid medications or pantoprazole or omeprazole, so are some like syrups also may relieve the antacid syrups also may relieve the pain. And also next one is the esophageal spasm. 2 to 30 minutes, so it may chance to get, they may feel the pain like a pressure, tightness and burning. So the pain also in the retrosternal I can closely mimic like a angina. Because of the spasm, the muscles are going to be constricted, the and also they may, this looks like is the angina symptoms. Peptic ulcers, so this is going to be the prolonged, so that means that there is no like a stopping, a continuations. So always the burning sensation at the exactly the epigastric region and sternal level. So it's the same like is the esophageal reflex, but esophagus a little bit the substernal. So it is epigastric in the gastric level. So and also relieved with food are also antacid. Sometimes if they take the proper food, so if the less spicy or also maybe is the cool food, so may chance to get the control, or like a yogurt or maybe with like a whole food means like a, whatever the probiotic food. So which one is going to be stop the irritation, so that food and also antacids are going to relieve the this type of chest pain. And also in case of gallbladder diseases, so it's going to be prolonged and also burning and pressure is going to be epigastric, and also it may follow the meal. If they take the meal, so the pain is going to be increased. And musculoskeletal is going to be variable, so it may aching pain, so aggravated by the movements. And also next one is the herpes zoster is also variable sharp like pain. So it may vesicular rash, that is the vesicles are going to be gives the pain. And also emotional one, so is going to be variable, so maybe situational factors, so anxiety or depression, so often detectable with careful history. So if you take the history properly, so we can rule out the like emotional type of the chest pain. So these are all the different types of the chest pain, the locations and characteristics and association of the chest pain. So if you know understand about the different type of the chest pain, their location and also associated features, we can easily differentiate to the cardiac chest pain. So if we rule out the cardiac chest pain and also non-cardiac chest pain, so we can prevent the mortality and we can prevent the heart diseases. But who have like a gastric problem and also like a esophageal problem, so they should not take the they should not feel like it's a cardio related pain. So that's why you should not bother about the seriousness or maybe. But if they take the medication, proper medication related to the causative factor, so we can prevent the chest pain. So all chest pains are not cardio related, so should not be panic. So rule out the causative factor, take the treatment according to the causative factor, so we can prevent the serious complication related to the heart problem. So that's all about the chest pain and also differential diagnosis. So these will help to rule out the chest pain. So that's all about today topic. In the next class we will discuss the another topic. So if you have any doubts related to this topic, you can send me a message so I can give the clarification about your doubts. So that's all about your topic. Thank you very much.